Fine. So now it is time for us to move to ophthalmology. So we have got one of the best centers in India, Aravind Eye Hospital, and Dr. Muthu Krishnan is the Vetero retinal surgeon from Aravind Eye Hospital. So already, as I told yesterday, more than 20 years ophthalmologists are doing stem cell therapy for cornea. Limbal stem cell therapy is being done for more than 20 years, but nobody has moved to retinal regeneration. So Aravind Eye Hospital, to my knowledge, is the first hospital in India to have published an article where they have shown that intravitreal PRP has helped in retinal regeneration. So that is why we have called Dr. Muthu Krishnan to present their study. Over to you, sir.
Thank you, sir. So, good morning all. My presentation for today would be platelet-rich plasma and retinal diseases. So that's regenerative medicine, the process of replacing, engineering or regenerating human cells, tissues or organs to restore or establish normal function. So currently there are two important technologies for discussion today. We have platelet-rich plasma and stem cell therapy. So what are the different fields in which it is extensively being used now? It's apart from ophthalmology, we have implications in dentistry, orthopedics, gynecology, dermatology and surgery including urology. So platelets are a natural reservoir of growth factors and bioactive molecules. We have discussed about various growth factors and it has been dealt with already by speakers. We have EGF, VEGF, FGF, PDGF and so on. So what is platelet-rich plasma? It is plasma obtained by density gradient separation of whole blood. And the average concentration is supposed to be around 10 lakhs per ml. So this is a process which includes centrifugation steps which separates whole blood into three layers as we can see in the picture there. That's a platelet poor plasma, platelet rich plasma and red blood cells. So what are these components of platelets? Offer wound healing by growth factors and cytokines and they promote cell recruitment and differentiation. Leukocytes facilitate tissue repair and wound healing, but a word of caution is that they are pro-inflammatory and immunogenic, so they can cause cell damage, so low concentrations may be required. Whereas red cells are absolute no, because iron in the heme releases reactive oxygen species during oxidative stress, causing host cell death. So these are different platelet concentrates available now: leukocyte-rich PRP, platelet concentrated plasma, non-coagulating PDF, platelet lysate, and the last three we will be discussing in the next slide. So important features of the last three platelet concentrates would be, so in platelet-rich plasma we have an anticoagulant. We use anticoagulant citrate dextrose, so no fibrin, and it releases growth factors and matrix proteins at a much faster rate. And similarly PRP gel, it has got an activator and low fibrin. Again, the properties are similar to platelet-rich plasma, and platelet-rich fibrin has high amount of fibrin and it has a large content of platelets too, but the release is much slower and long lasting. So why this advent of PRP and why there's so much hype about PRP now? It's autologous, so no immunocompatibility issues at all. Abundant growth factors it supplies, improvement of both anatomical and functional outcome which can be translated to visual benefit, easy to collect and easy to prepare. So how do we prepare it in our operation theatre? So PRP would be prepared inside the operation theatre with, in a 20 ml syringe. We fill with 2 ml ACD, 18 ml blood plus 2 ml ACD. And then we inject into a Dr. PRP kit. The picture shown on the right is a Dr. PRP kit. Through the upper part we inject this and the intercommunicating tubes. So this is placed in the REMI PRP centrifuge machine. It's called the REMI PRP centrifuge machine, which offers double centrifugation. The first centrifugation is about 12 minutes, which separates plasma from RBC. And these two compartments are locked by rotating the knob below, and it's centrifuged again for 6 minutes to achieve adequate platelet concentration. So whatever is highlighted in the red arrow, that bottom part of the upper part, that is platelet-rich plasma. Sorry. So platelet-rich plasma being heavier settles at the bottom of the upper compartment, highlighted in red, and platelet poor plasma ascends to the top. So the platelet poor plasma is discarded and PRP is used within 30 minutes of preparation. So we can also prepare topical PRP drops. So how do we do it? So platelet pellet extracted, resuspented with platelet poor plasma, and the patient is advised to shake wires before use and instill it 6 times a day for 4 weeks. So again, this is a process of double centrifugation which yields 10 vials. The patient can use this for 4 weeks, 6 times a day. So this is used for ocular surface disorder like neurotrophic keratitis, corneal non-healing ulcers and so on, or severe forms of dry eye. Contraindications, as we all know, anticoagulant drug therapy, coagulopathies, thrombocytopenia, hemodynamic instability, and so on. So in ophthalmology, we have these three subspecialties which extensively use platelet-rich plasma: cornea, retina, and glaucoma. So the modes of application can be topical eye drops, especially for corneal conditions like dry eye. It can be used intracameral into the anterior chamber for ocular hypotony in glaucoma. Post trabeculectomy surgery for glaucoma, when we encounter a patient with ocular hypotony, but there is low intraocular pressure, intracameral injection of PRP has shown some benefit. Intravitreal injection of PRP has been used for refractory macular holes, which we'll be discussing soon. And subretinal injection is still research. Subretinal injection under the retina. So this is used for retinitis pigmentosa, which is a kind of retinal dystrophy, and for geographic atrophy and so on. We'll be discussing this soon. So in cornea is used for dry eye, ocular surface syndromes, and corneal ulcer. And glaucoma for ocular hypotony, post trabeculectomy surgery, when we have ocular hypotony, low intraocular pressure less than 6. We can have an intracameral injection of PRP offering some benefits. So in retina, these are the constellation of disorders in which PRP has been used, and the first one is time tested and well proven, macular hole. So for a refractory macular hole which fails to close after a conventional surgery, or we have a patient who has not responded to surgery, is unclosed after surgery, it's of very much benefit. We can also use it for retinitis pigmentosa, endophthalmitis, geographic atrophy, and deep capillary ischemia, but these 4 conditions are still under research. So this is our experience with macular hole. So macular hole, for an introduction, is a vitreoretinal interface disorder which is a partial or full thickness neurosensory retinal defect involving the anatomical fovea. The picture shown below shows an optical coherence tomography scan, an OCT scan, which shows a full thickness macular hole there. So this can be mostly idiopathic, above 60 years of age, or it can be myopic or traumatic, and the whole list of etiologies. So these are the theories for a macular hole formation. It could be traumatic, vitreomacular traction, degeneration, vascular, and so on. So this patient would complain of blurring of vision and metamorphopsia, distortion of images, metamorphopsia. And the picture on the right shows a Watsky-Allen test, which means a slit lamp beam appears to be broken to the patient. When you ask the patient whether he can appreciate a vertical slit, the patient appreciates a break in the slit. So this is the classification of macular hole. There are 4 stages. And the picture on the right shows an impending macular hole, stage 1. Right down shows occult macular hole, again stage 1. And this is full thickness macular hole, the picture below on the left, full thickness macular hole from which can be 2, 3 or 4. So this is the stage in which it is treated, full thickness macular hole. So this is a lamellar macular hole. Research has shown that even in lamellar macular hole, that is partial thickness defect, as we can see in the OCT picture down, the photoreceptors are still intact. In this condition also, platelet-rich plasma can offer benefits. The one on the right is a pseudo hole which accompanies an epiretinal membrane. It does not require treatment most of the times. So our topic today is refractory macular hole. So this could be a full thickness macular hole which has reopened after surgery. We have done a conventional surgery for macular hole, but the hole has reopened, or it has never closed. So both these entities, whether it's reopened after surgery or a persisting macular hole, both are classified as refractory macular hole. So this depends on certain risk factors like the size and the duration of the macular hole, or associated myopia, trauma, etc., or surgical factors like partial removal of traction, inadequate internal limiting membrane peeling, or inadequate gas tamponade. Or it could be poor compliance, because we advise strict prone positioning for 2 weeks. So patient may not comply with this. That can also cause a reopen hole or a persistent hole. So what are the adjuncts in macular hole surgery which have promised enhanced closure rates of the macular hole? For non-ocular adjuncts, the first one is platelet-rich plasma. Then we have whole blood clot or human amniotic membrane transplants. In ocular adjuncts, we stuff the hole with lens capsule, internal limiting membrane flap from the retina, or a retinal graft, a full thickness graft. So this is a conventional surgical procedure for a macular hole. This is called a pars plana vitrectomy, in which we do induction of posterior vitreous detachment, a peeling of hilum. So the picture below represents a peeling of internal limiting membrane. The picture above shows an internal limiting membrane stain using a brilliant blue dye. And this is followed by gas tamponade. So what extra we do in PRP, when a patient has a refractory macular hole which is not closed with conventional surgery, we just inject 0.1 ml of platelet-rich plasma onto the fovea at the end of surgery. So this is conventional surgery in which a PVD induction has been done. The picture below shows internal limiting membrane peeling, and lastly gas tamponade. So how does PRP help in this procedure? So PRP has platelets and growth factors which produce Muller cell activation and signal transduction. So this is supposed to promote some migration, proliferation, tissue remodeling and gliosis, thereby closing the macular hole. So these are the types of macular closure. The one on the left is type 1, on the right is type 2. So the one on the left is ideal. So this is full thickness regeneration of the neurosensory retina. As we can see, the hole is fully closed after surgery in B. The one on the type right is a partial thickness, partial closure, which means it's not elevated anymore, it's flattened edges, but still the neurosensory retina is not fully regenerated. So type 1 or type 2 closure can happen after macular surgery. And whatever is highlighted, this is Rossi's classification, A, B and C. So A is just an open hole, it can be open after surgery, and B is ideal. B1A is the ideal condition where the hole is fully closed after macular surgery. If we use a filling tissue, say platelet plasma, we classify into C. A filling tissue has been used, again 2A in C is ideal. So the filling tissue has completely filled up the retinal defect. So this is our paper from Aravind Hospital, Madurai. We have proven efficacy of platelet plasma in refractory macular hole. So whatever seen in the picture on top is after the first surgery, the hole was still refractory. The picture in the middle one shows the regeneration of layers after 1 month of platelet plasma. The picture below shows after 6 months, we can see all the layers are almost regenerating to normal, and the visual acuity improves in a matter of 6 months, not in 1 or 2 months. It takes time. So we have two scenarios from our hospital. So the first picture is a patient of a 30-year-old male with a full thickness macular hole, and he underwent a first surgery which was a failure, so it was still a refractory macular hole. A second surgery was done, platelet plasma was done, and then after 1 month the vision improved to 6/24, not mentioned there, and at the end of 6 months he improved to 6/9. That is just last but one line in Snellen's chart. So very good visual improvement was shown in this patient, probably reflecting on the age also. Younger age, better the benefits. So there's another patient, 66-year-old with a visual acuity of 1/60, a full thickness macular, which was quite chronic, so not so good prognosis. So we didn't expect it to close, and it did not close. So after the first surgery, it did not close. And then we used platelet plasma, the second surgery, and the visual acuity improved to 6/24 at the end of 6 months. So this is a paper comparing platelet plasma and internal limiting membrane flap. That's one of the conventional surgeries for macular hole. So we compared the two, and then this is only for large maculoles more than 600 microns. The study was done only for large maculoles which are more prone for failure. And then we have shown that excellent anatomical closure and visual impairment, both are comparable. Group A and Group B were very much comparable, and PRP was as safe as and effective as an inverted hilum flap for macular hole. So these are other papers in literature. So effect of autologous platelet concentrate for idiopathic macular hole has been well proven. Good anatomical success has been shown in these two papers with 100% macular closure rate at 1 and 6 months in a small cohort of patients, 13 eyes. And this is another paper which shows that lamellar macular holes can also be treated with platelet plasma. We can see preoperative and postoperative pictures all have closed well. So the second is endophthalmitis. We are still in the infantile stages. We are proving the benefit of platelet plasma in Aravind Eye Hospital. So why is this basis? So tissue infections. So how does PRP exert its effect? So it releases antibacterial proteins like connective tissue activating peptide or chemokines, thymosin, fibronopeptide and so on. And it has both bactericidal and bacteriostatic actions, and it is synergistic with beta-lactam and vancomycin. So these are the organisms against which the platelet plasma has shown sensitivity, Staph aureus, Pseudomonas, E. coli, Klebsiella and so on. And the mechanism is that it inhibits enzymatic activity and DNA proteogenesis, increases membrane permeability, release of antimicrobial peptides and complement fixation factors, and also it has got an antibody dependent, reactive oxygen species dependent cytotoxicity. So hence its antibacterial property. So this has applications in other specialties like for chronic skin ulcers, hidradenitis, osteomyelitis and dental extraction for its anti-infective property. Now, what is endophthalmitis? It's defined as an inflammation of inner coats, the choroid and the retina, with intraocular colonization of organisms, and the vitreous is full of exudates. So that's a B-scan picture, shows exudates in the vitreous. The picture below is a fundus picture. Nothing is visualized because of the exudates in the vitreous. So these are the usual spectrum of organisms causing acute postoperative endophthalmitis. Can be Staph epidermidis, Streptococcus, and so on. And in our study, in in-house study, we are recruiting patients with acute postoperative endophthalmitis of less than 7 days onset. B scan proving the infection. Age more than 18 years with no acid ocular pathology and immunocompetent status. This is how we have segregated the patients. So core vitrectomy with intravitreal antibiotics is the mainstay of treatment for endophthalmitis. That will be done in one group. The second group would be given core vitrectomy antibiotics with adjuvant autologous PRP of 0.2 ml. So we are expecting to prove functional outcome based on visual acuity and media clarity, that is visualization of the fundus, and a structural outcome based on optical coherence tomography scan. This we are just recruiting the patients. The study, a small pilot sample would be happening soon. So the rest is just research. For retinitis pigmentosa, so what is this? It's a hereditary disease resulting from abnormalities in RP and photoreceptors, and primarily affecting rod photoreceptors, then cones. The patient would complain of night blindness and tunnel vision, gradually resulting in blindness above the age of 50. So what does this paper say? So this has evaluated the effect of subtenon injection of PRP, subtenon injection monthly for 3 months. That's how they have taken, and significant visual improvement has been proven. So why this? Because retinitis pigmentosa has been shown to deficiency of growth factors causing apoptosis of growth factors. So what does PRP do? It recovers the photoreceptors in the dormant phase and prevents them from entering into apoptosis. So this they have tried topical application as well as subtenon injection. This is subtenon injection being performed in the infratemporal quadrant, and that's the pathway by which it reaches the photoreceptors through the suprachoroidal space, subretinal space, and photoreceptors. So this study has evaluated the outcomes based on the visual acuity, visual field, the retinal sensitivity, microperimetry, which assesses the retinal fixation stability, optical coherence tomography showing the microstructural organization of the retina, and ERG, electroretinogram, showing the viability of retinal cells. So this paper has shown some improvement or marginal improvement in the visual fields as well as in microperimetry, that is fixation stability. We can see more orange area means it has improved. So this is improvement of retinal sensitivity in a retinitis pigmentosa patient after subtenon injection of platelet-rich plasma. Geographic atrophy is another end-stage condition of age-related macular degeneration, a very common disorder causing visual loss above 65 years of age, again caused by all the atrophy of all these retinal cells. So again, this study has shown a small cohort, again 13 eyes, it has shown subretinal injection of cord blood PRP. So cord blood PRP, it's a non-autologous, it is done by pooling of PRP from babies, and it should be used immediately after injection. And this was done by subretinal injection. So after vitrectomy, 41 gauge cannula and subretinal injection of 0.5 ml of cord blood PRP was done, and supine positioning so that the injection stays at the fovea. And they have measured this visual acuity and central macular thickness along with OCT parameters, and the arrows show that there is some regeneration of retinal layers few months after PRP injection. Lastly, we have deep capillary ischemia, another hypoxic condition affecting the retina. It's also called paracentral acute middle maculopathy. A patient comes with paracentral scotoma. It's a hypoxic event, basically driven by reperfusion injury. So this is the middle and deep place. We can see a band-like white highlight there. So that is the reperfusion injury, that is capillary ischemia. So some different types, type 1, type 2, and the level of the ischemia varies. So this study has shown that electromagnetic stimulation along with subtenon injection of PRP is excellent for recovery of ischemia. So how do they do this? Again, photoreceptors and other cells may enter into a dormant state resulting in oncotic necrosis or oncosis, and the PRP can help by increasing the cytokines, chemokines, and growth factors, and also proliferation activation of reparative cells. This study did PRP along with electromagnetic stimulation and proved an improvement in the deep retinal capillary density, that is some improvement in the capillary density in the retina after EMS plus PRP. So this is what we have learned today, that macular hole is very much useful. We have proven evidence, and others are still in research: retinitis pigmentosa, endophthalmitis, geographic atrophy, and deep capillary ischemia. So PRP is a boon in regenerative medicine. It's an emerging therapy in retinal disease because of its growth factors and bioactive molecules. Thanks to them, it has a proliferative, anti-apoptotic, and anti-infective property, and the research is still on. So I'd like to wind up. Thank you.